Good morning, everybody. I'd like to introduce Dr. Eugene Yang, my good friend and partner out at the Eastside Specialty Center. Dr. Yang is clinical professor of medicine in the Division of Cardiology and holds the Carl and Renee Benke Endowed Professorship for Asian Health. He's medical director of our UW Medicine Eastside Specialty Center and co-director of the UW Medicine Cardiovascular Wellness and Prevention Program. He's also chair of the Hypertension Working Group for the ACC Cardiovascular Disease Prevention Council and was appointed chair of the council starting in 2021. It's my pleasure to introduce Dr. Eugene Yang.
Thank you, Alec. I hope everyone can hear me now. So what I want to do today is talk about the prevention guidelines that were published last year. I think I might have bitten off a little bit more than I can chew. So I'm going to focus on a few areas in the new prevention guidelines this morning. So here are my disclosures. And so here's how I like to format this talk. So I'll first sort of review the extensive guidelines that were published in 2019. I'll then present a case of how we can apply these guidelines in clinical practice, and then I'll finish with a few take-home points. So as you know, the ACC published guidelines in 2019. There was a comprehensive assessment of health and cardiovascular risk assessment, and focused on 5 key areas that I will present in this talk today, including aspirin, blood pressure, cholesterol, cigarettes, diabetes, diet, weight optimization, and exercise. So in this talk, I will review each of these areas in varying levels of granularity, some probably less than others because other talks have already focused on this through our Grand Rounds presentations. So I think this is a good graphical description or representation of the new prevention guidelines. So you can see in this wheel that all of these things that we just talked about are covered in the scope of these guidelines. And as I said, I will focus on some of the areas with respect to prevention of cardiovascular disease. So one of the things in the guidelines that I think were very important were really looking at a patient-centered approach to comprehensive atherosclerotic cardiovascular disease prevention. So as you can see in the guideline, that a team-based approach was recommended to control risk factors associated with ASCVD. Shared decision-making that has been previously recommended in other guidelines, such as the blood pressure and lipid-lowering guidelines, were also part of the overarching recommendations. And finally, something that I think is a little bit different and important to address that really is beyond the scope of this talk is around the social determinants of health that should inform optimal implementation. So there was recognition that this is an area that we have not really spent a lot of time focusing on. I can tell you that at ACC 20, there was a study that was presented that looked at some of these social determinants of health, including food insecurity or housing insecurity. And in this particular study, they found there was a 50% increased risk of cardiovascular morbidity and mortality associated with those who self-reported both housing and food insecurities. So I'm not going to talk about this too much. Then most people in the audience are well of sort of the overarching principles around ASCVD risk assessment. So you can see here that for those who are between 40 to 5 years of age, that the pooled cohort equation should be used to calculate 10-year ASCVD risk. And that really guides decision-making around blood pressure treatment, as well as indications for lipid-lowering therapy based on that 10-year risk assessment. And then you can see some of the other things that are outlined here for those who are between 20 to 39 years of age, using that same pooled cohort equation and reassessing these patients every 4 to 6 years. Sorry, not using the 10-year pooled equation, using the 30-year lifetime equation. And those who are borderline risk, you can see in the third point here, for those patients, it is useful to use risk-enhancing factors that were described in the lipid-lowering guidelines, which we'll talk about shortly, and those at intermediate risk, now defined as 7.5 to 20%, for those patients to consider additional ways of assessing risk, such as using a calcium score. So this just highlights the risk enhancers that were published as part of the lipid-lowering guidelines in 2018. And I'm not going to belabor the points here, but as you know, there are a lot of things that we can use to sort of put patients into higher risk categories, such as family history, premature atherosclerotic cardiovascular disease, those with chronic kidney disease, patients who have premature menopause, and their high risk race and ethnic groups, especially South Asians. And then they also included some biomarkers, as you can see here, such as elevated lipoprotein (a), ApoB, CRP, elevated triglycerides, as well as an ABI that's less than 0.9. So these can be used to help discriminate patients that we might want to categorize into higher risk groups and therefore potentially be more aggressive in treatment of both blood pressure and cholesterol. So I'm going to highlight and spotlight some of our colleagues throughout this talk. So if you're not included, I apologize. I do not know some of the phenomenal things that you do. So here I'm showing aspirin. So aspirin obviously is used as an analgesic, and we have lots of headaches recently from COVID-19. And so our fearless leaders, Dr. Stout and Dr. McClellan, have been dealing with this. So that's why they're represented here in this first slide. So let's talk about aspirin in a little bit of detail, because there's certainly a lot of controversy around aspirin for primary prevention. So I'm going to highlight some of those studies. So in the new guidelines that came out last year, you can see that low-dose aspirin could be considered for primary prevention for those between 40 to 70 years of age at higher ASCVD risk, but not increased bleeding risk. And you can see the level of sort of recommendation is only 2B, I think because of a lack of clear data supporting the use routinely in clinical practice. For those who are over the 70 years of age, aspirin is not recommended and may cause harm for patients over the age of 70. And you can see that it's also not recommended for those who are at increased risk of bleeding. So I'm going to go into some detail about the 3 primary prevention trials for aspirin that were published in the summer of 2018. So there were 3 studies that were published around the same time and presented at the European Society of Cardiology meeting. So you can see the 3 studies outlined here: the ARRIVE trial, the ASCEND trial, and the ASPREE trial. And they focused on different populations, which we'll review individually. So the ARRIVE trial was a primary prevention study to evaluate the potential benefit of aspirin in an intermediate risk population. So they used a population that they deemed to be between 10 to 20% 10-year ASCVD risk, and they used several different scoring systems, including Framingham and the European score system, to identify an intermediate risk population. You can see that it was a randomized placebo-controlled trial of 7 countries, mostly European countries, and they had multiple risk factors, as you can see indicated here. And it was a relatively large study of over 12,000 patients with a median follow-up of about 5 years. And the primary endpoints were composite outcome of first occurrence of cardiovascular death, MI, unstable angina, stroke, or TIA. You can see the primary bleeding endpoint, the primary safety endpoint was bleeding. And if you look at the baseline characteristics, the average age was around 64, only about 30% women, and was very not ethnically diverse. So 98% of the participants were white. So unfortunately, as I will present in some of the other trials, they unfortunately observed very low event rates, and as a result had to increase the length of the study and add additional primary endpoints, including TIA and unstable angina, to increase the power of the study. And what you see is that at the end of that 5-year period, there was no benefit in the primary endpoint, and there was obviously higher rates of bleeding, almost twofold increased risk of bleeding. And I think most importantly, really didn't address the study question, which was to study an intermediate risk population. And when they looked at the data in terms of what the actual risk of this group was, it was less than 10%. So it really didn't study the intermediate risk population for primary prevention use of aspirin. The ASCEND trial was the second study that looked at the potential benefit of aspirin for patients with diabetes without a history of overt atherosclerotic cardiovascular disease. This was a study that was performed in the United Kingdom and randomized patients to 100 milligrams of aspirin versus placebo. Most of the subjects had, the subjects were over 40 years of age, had no overt ASCVD, and no specific clinical indication for aspirin. Also a large study of 15,000 patients. The mean follow-up was about 7.5 years. Again, not very ethnically diverse, but 94% had type 2 diabetes as opposed to type 1. The primary endpoint was similar to some of the other studies that I will present, and the primary safety outcome was the first occurrence of a major bleeding event. And then secondary outcomes were looking at rates of GI tract cancers, as well as composite of serious vascular events or arterial revascularization. So in this trial, they did see a small net clinical benefit. Again, because of low event rates, they had to add TIAs to the primary endpoint to increase the power of the study. And you can see that there was about a 12% relative risk in the primary endpoint that was statistically significant. However, the bleeding risk was higher in the aspirin treated group by 0.9%. So overall, the net clinical benefit was really minimal due to the increased bleeding risk. And finally, they observed there was no reduction in the rate of GI malignancies. So this trial, even though it did show a slight clinical benefit, many interpreted this study as being really clinically net neutral because of the higher rates of bleeding. The final study that I will discuss is the ASPREE trial, which was a primary prevention trial to evaluate the benefit of aspirin in older patients that were at least 70 years of age or at least 65 if they were Black or Hispanic. This was a study that was conducted in 2 countries, in the United States and Australia. Again, a large study of over 19,000 patients, of which the majority were coming from Australia. The mean follow-up in this study was about 5 years, and you can see that it was more ethnically diverse. Of the US participants, 53% were Blacks and Hispanics, and the median age was 74. So the primary endpoints for this trial were a composite of death, dementia, or persistent disability. So you can see that the primary endpoint was not looking at cardiovascular outcomes, which was included as a secondary endpoint in the clinical trial. But unfortunately, they had a lot of challenges with the trials. And so they actually separated it out into 2 publications in 2018. One that really only looked at all-cause mortality, didn't really address the issues of dementia or disability. And the second one really focused on the secondary outcome, which was cardiovascular morbidity and mortality and safety. And interestingly, in this study, they found that there was higher mortality associated with aspirin treatment by about 14%. And this seemed to be driven by an increased rate of cancer-related deaths. So not specifically certain types of malignancies, but generally across the board, there seemed to be higher rates of cancer-related mortality, which they really had challenges trying to explain why they observed these differences. You can see that the cardiovascular event rates were very similar between the 2 groups, and the bleeding rates were obviously higher by about 40%. So this study, even though the data was presented in an unorthodox manner, really did not show any clear benefit in treating patients over 70 for primary prevention with aspirin. I think some of the unresolved questions that emerge from this issue about aspirin for primary prevention is for those patients who are between the ages of 40 to 70, who are the patients who are the best candidates for using aspirin for primary prevention? And this is something that really hasn't been clearly, I think, elucidated from the studies that we have currently. So in my clinical practice, I think that when we have patients who have multiple risk factors, in particular, perhaps those who have uncontrolled risk factors such as diabetes, poorly controlled blood pressure, or lipids, maybe those are the patients in the setting of a lower rate or low risk of bleeding. Those might be patients for whom aspirin could be utilized for primary prevention. Other things that we have a lot of uncertainty about are what do we do with patients who have subclinical atherosclerosis based on evidence of coronary calcium scores, or patients who have evidence of abdominal or aortic calcification. Are those patients candidates for aspirin therapy? And at what calcium score do we define them as being an ASCVD risk equivalent in a high-risk population, let's say greater than 20%? We don't have studies really that have addressed when aspirin should be used. However, there was a recent study that came out in Circulation in the last few weeks that analyzed data from the MESA trial to try to use calcium score for personalized allocation of aspirin for primary prevention. And when they looked at the MESA data, when they looked at patients who had a calcium score of greater than 100 or 400, they found that there appeared to be a modest net clinical benefit. So the number needed to treat at 5 years to prevent one event was 140 and 140 patients, which is really very modest, but did show a benefit in terms of the number needed to treat over that 5-year period versus the amount of harm associated with it in terms of bleeding. You can see that a calcium score of 0 was associated with more harm than benefit, clearly. And the calcium score was better, actually, than aspirin, than using the pooled cohort equation, such as an ASCVD risk greater than 20%, for determining whether aspirin might provide some net clinical benefit. So blood pressure. So I have two of our colleagues, Dr. Kearney and Dr. McCabe. So I think their blood pressures are probably elevated in the cath lab when they're doing procedures. I think it's interesting to see how young everybody looks here. So I think these pictures were probably. Okay, let's talk about blood pressure. So blood pressure guidelines were published in 2017. You can see that there were major changes made to blood pressure definitions, including lower targets. As a result, more patients were then given a diagnosis of hypertension. And then finally, I think underlying all of the different guideline recommendations was a much stronger emphasis on lifestyle changes. So why was there a change made in 2017? I think we know that hypertension is a leading cause of death and disability adjusted life years worldwide. And in the United States, it accounts for more cardiovascular deaths than any other modifiable risk factor, and is really second only to smoking as a preventable cause of death. And when we look at the NHANES survey of deaths from patients with coronary heart disease or stroke, the majority of them had a concurrent diagnosis of hypertension. So this sort of reviews the new blood pressure categories that are outlined here. I don't want to go into this, but you know that now stage 1 hypertension is defined as a blood pressure between 130 to 139, or a diastolic blood pressure of 80 to 89, and stage 2 hypertension that was previously stage 1 hypertension is defined for individuals with blood pressures greater than 140 on the systolic side and greater than 90 on the diastolic side. I think one of the key things to point out is that I think when the guidelines came out in 2017, there was a lot of trepidation around the fact that many more people would be diagnosed with it, but what impact did this really have on those who were recommended for potential antihypertensive therapy? So what you can see here is that the actual proportion of patients for whom pharmacologic treatment was recommended was really very modest at 1.9%, even though there was a 14% increase in those who now had a diagnosis of hypertension. And that translates into about 4.2 million people out of the 81 million people for whom pharmacologic treatment was recommended. So this just highlights the fact that really some differences among the different guidelines. So JNC7, the ACC guidelines, ESC, ESH, and NCQA, which is basically used for determining outcome and quality metrics. So you can see there was clearly a lot of differences of opinion, and even more so when we compare these guidelines to the primary care guidelines through the ACP and the AAFP. I think one of the concerning things that we have seen are the trends that show that there's increased morbidity and mortality, and so cardiovascular death rates, while they had been trending down for many years, you can see in the last few years the cardiovascular death rates in the United States have actually been increasing. And in this study that was just presented at ACC 20, looking at the NHANES data, when they looked at hypertension-related cardiovascular mortality over about a 10-year period, you can see that those mortality rates for cardiovascular disease that was attributed to hypertension seemed to be rising in many regions of the United States, in particular in the South. But the trend is clearly moving in the wrong direction with respect to high blood pressure. So again, I don't want to belabor this point, but again, these are the recommendations. I think one of the key things about the guidelines are that for stage 1 hypertension, if the 10-year ASCVD risk is less than 10%, you can see that non-pharmacologic interventions, so behavioral lifestyle changes, are the primary focus. And it's only when that risk is over 10% that pharmacologic therapy is recommended for treatment in that population. Hence why the number that pharmacologic treatment was recommended based on the change in the guidelines is relatively small. So I think in clinical practice, some of the things that I try to talk to patients about are ways to try to optimize their blood pressure through lifestyle recommendations. And so I talk to patients about the rule of fives, which I think helps them understand the potential benefits of specific lifestyle interventions. So you can see here that things like weight loss, healthy diet, reducing sodium intake, and increasing intake of dietary potassium in general has about an impact of reducing their systolic blood pressure by about 5 points. Obviously, the DASH diet, which incorporates a low sodium diet as well as diet enriched with primarily fruits and vegetables, has a greater benefit, although the DASH study was a relatively small study and short-term study. But for patients in general, I instruct them about the fact that if they lose about 1 kilogram of weight or 2 pounds, that can translate into 1 millimeter reduction in blood pressure. So for about every 10 pounds of weight that they lose, that could potentially reduce their systolic blood pressure by 5 millimeters of mercury. So that's where this rule of fives comes from. And then if we look at some of the other interventions, so aerobic physical activity, dynamic resistance training, even isometric exercises, or moderation in alcohol consumption, which might be difficult during these times, also achieves about a 5 millimeter reduction in systolic blood pressure. So these are ways to help inform patients of opportunities with lifestyle changes to have an impact on lowering their blood pressure. So I want to highlight an interesting study that gets into an issue that, again, I didn't have enough time to really discuss around the impact of sodium intake and blood pressure, and addresses the interesting question about primordial disease prevention, and that what we really need to be doing is focusing on lifestyle interventions, not as we become adults, but much earlier. So these are two tribes in South America that have limited exposure to Western civilization and are primarily hunter-gatherer populations. So the Yanomami Indians are very much hunter-gatherers and very limited exposure to Western culture. The Yakwana Indians, you can see they're wearing jeans, so they have more exposure to Western diet and food. And so it's interesting to look at the impact of that on their blood pressure. And so it raises the question about, is high blood pressure really a consequence of aging, or is it really an environmentally driven disease process? And so in this particular study, they looked at the Yanomami Indians and Yakwana Indians over their lifespan from age 1 to 60. And what they observed was that over that sort of age period, that there was really no change in blood pressure over time. And their average blood pressure, you can see, was only 95/63. The Yakwana Indians were exposed to some processed foods and high Western diet. And you can see their blood pressure was higher at 104/66. And they did have some increase in blood pressure by about 0.25 millimeters per year starting in early childhood, which is much lower than what we see in the United States, which is 1.5 to 2 millimeter increase in blood pressure for boys and girls. And you can see, compared to the Yanomami Indians, by age 50, the Yakwana Indians' average blood pressure was 16 millimeters higher. So this was just published a few years ago by some researchers out of Johns Hopkins. And this just shows a scatter plot looking at the Yakwana Indians based on age, and you can see the trend of blood pressures going up, versus the Yanomami Indians from age 1 to 60, that there was really no change in their blood pressure over that period of time. Both systolic and diastolic blood pressure did not change between ages 1 to 60. So we can talk a little bit about cholesterol. So I chose, Dr. Mormon could have been used in many slides, but Dr. Mormon and I were involved in the Fourier trial, and Dr. Zhao has also been interested in cholesterol research in PCSK9 studies, so that's why I have shown them here. I'm not going to spend a lot of time talking about the cholesterol guidelines, since I think this has been regurgitated many times. But again, the new guidelines in terms of management and treatment are based on using the pool cohort equation that I showed earlier, and the 2018 cholesterol management guidelines. We already spoke earlier about sort of the different risk categories of borderline, intermediate, and high risk, using the 30-year risk assessment tool and monitoring patients between the ages of 20 to 39 every 4 to 6 years. And key highlights that I think are not really changed from the previous iteration from 2013 are that the high-risk groups should be treated with lipid-lowering therapy, those with overt atherosclerotic cardiovascular disease, those with diabetes, and those with a likely genetic etiology with an elevated LDL of 190, for those patients likely to have familial hypercholesterolemia. So again, additional risk factors that we discussed earlier, those individuals who have risk enhancers are outlined here. We will talk a little bit more about calcium score later in this talk. And then for very high risk patients, the LDL target is less than 70. So this is a departure from the previous guidelines where there was no clear specific LDL target set, and which was certainly controversial when the 2013 guidelines were published. So I'm just going to briefly review the primary prevention algorithm. So I think we've already talked about it. I think the only group for those between the ages of 0 to 19 where treatment is recommended are those who have familial hypercholesterolemia. Again, we already talked about this group of those if they are in potentially a group with elevated cholesterol and a family history, so an LDL of 160 or greater, and if they have premature atherosclerotic cardiovascular disease in their family, those are patients for whom you might consider treatment. And then this is the primary target group that we have a lot of, I think, controversy is this group between 40 to 75. And you can see here, so again, if the patients are borderline risk or intermediate risk, for the borderline risk group, there isn't a lot of evidence necessarily to support treatment. I think the group where we face a lot of challenges trying to persuade patients about treatment are in this intermediate risk category of 7.5% to 20%. And so again, this is where risk enhancers can be useful in trying to persuade patients or push them to more aggressive intervention. I think calcium score is certainly useful in this population when there is risk indecision. And I think that Dr. Mormon and I and others certainly use this frequently in clinical practice to help with the decision-making process. And then for high-risk patients, those patients definitely should be treated with aggressive, high-intensity lipid-lowering treatment. I think secondary prevention is quite clear. I think the only thing I think to talk about that's unique to the new guidelines from 2018 is that the very high-risk categories really have been redefined in terms of those who have major events such as heart attack, recent ACS, PAD, and additional events or risk factors such as hypertension, diabetes, smoking history. Those are patients for whom you want high intensity treatment as well as a target to lower their LDL below 70. So this group was sort of identified in the updated guidelines from 2018 that were not really clearly described in the previous 2013 recommendations. So I didn't want to show anybody here since I hope none of our faculty are smoking. So let's briefly review the recommendations from the prevention guidelines. So I think one of the unique things about the updated guidelines was now to use tobacco use as a vital sign at all visits when the patients are seen in clinic, and that we need to take a much more proactive role as providers to advise patients to quit either through behavioral or pharmacologic approaches. And the two pharmacologic approaches that are recommended currently, or the types of recommendations, are around nicotine replacement therapies, and then two pharmacologic interventions are varenicline or Chantix and bupropion. One of the things that has raised a lot of controversy is around the role of e-cigarettes in smoking cessation. And so I think the reason for that is around some studies that suggest that e-cigarettes might help promote smoking cessation, but as I point out here, that evidence is very weak. One study that I highlight here, I think addresses the concerns that are raised and why e-cigarettes are not recommended for smoking cessation. So a study that was published in the New England Journal of Medicine last year compared e-cigarettes versus nicotine replacement products. And what you can see is that although abstinence rates were higher at 18% versus about 10%, when they monitored these patients at a year, you can see that 80% of the patients were still using e-cigarettes in the group randomized to that arm, whereas only 9% were still using nicotine replacement therapies in the nicotine replacement group. So what we see is that, unfortunately, instead of inhibiting smoking cessation, we're actually promoting persistent nicotine addiction, and we're really not removing that potential addiction from these patients. And so clearly we need further exploration of this particular topic before I think anybody would be willing to recommend e-cigarettes as a way to promote smoking cessation. So let's talk about diet. So I know Deanna, one of our excellent nurse practitioners and EP, has a very active interest in this, and Dr. Dean, I think he likes posting lots of blogs about his food interests, so that's why I've highlighted the two of them here. So let's talk about diet. So I could clearly spend an entire hour talking about this. We heard an excellent lecture last year from Dr. Williams, so I'm not going to go too much into plant-based diets today, but review what the ACC recommendations are. And you can see that the recommendations do promote both a plant-based as well as Mediterranean diet. And the diets obviously should be enriched with things that are very strong components of the Mediterranean diet that I've outlined here: fruits, vegetables, legumes, nuts, whole grains, and fish. We should clearly be emphasizing replacement of saturated fats with mono and polyunsaturated fats. We'll talk a little bit about sodium and cholesterol intake, in particular the cholesterol intake, and that clearly we should reduce the consumption of processed meats, refined carbohydrates, and sweetened beverages. So let's talk a little bit about the Mediterranean diet and fish oil, since I think there have been a fair number of studies recently that have looked at this. The largest study that has evaluated the Mediterranean diet is probably the largest randomized clinical trial of dietary intervention that comes from Spain, that was originally published about 7 years ago in the New England Journal of Medicine, the PREDIMED trial of about 7,500 patients, was actually retracted and then reanalyzed and republished in 2018 because of challenges with randomization in the clinical trial. I think the good news is that when they reanalyzed the data, the primary endpoint was the same. In this study, patients were randomized to the typical low saturated fat diet versus consuming up to 1 liter of olive oil a week. The patients were actually required to at least consume 4 tablespoons of olive oil a day or 30 grams of nuts. And what you can see is that in the groups that were randomized to the Mediterranean diet, there was about a 30% reduction in the primary endpoint, but this was mostly driven by a reduction in stroke. I think more interestingly are studies around fish oil supplement data. I think there have been many studies that have looked into this particular topic. So I just highlighted 3 studies here. So the VITAL, the STRENGTH CF, and ASCEND trials. The ASCEND trial was also the ASPIRIN trial that earlier, and these were lower doses of a combination of EPA, or the eicosapentaenoic acid, and DHA, docosahexaenoic acid, and did not show any cardiovascular benefit. However, studies that have looked at the eicosapentaenoic acid, including the REDUCE-IT trial published in 2018, and GELIS, which was published more than 10 years ago from Japan, did show lower cardiovascular event rates. So there is a question about whether, the EPA specifically, which has been postulated to have possible anti-inflammatory effects, may have a specific benefit over the combination of 2 omega-3 fatty acids. And in fact, at ACC 20, there was a recent analysis of the REDUCE-IT trial looking at measured EPA levels that seem to correlate most strongly with cardiovascular outcomes, more so than looking at other factors such as total cholesterol, LDL, and HDL levels. So that does suggest a potential link between EPA and cardiovascular outcomes. So other areas I think that in clinical practice we are questioned about frequently are about cholesterol-rich foods. Are they good or bad? The data for this is quite mixed. There are clearly studies that show that higher cholesterol intake in our diets do translate in general to higher total and LDL levels that are measured in those patients. And in fact, some studies do suggest an increased risk of cardiovascular events with high cholesterol intake, but this is often associated with other foods that have cholesterol in them, which are high in saturated fat. So it is difficult to unlink sort of the cholesterol intake from the fact that many of those foods that are ingested have high saturated fats, which then obviously increase total and LDL, and in many cases the HDL cholesterol levels. Of note, I think it's important to point out a recent circulation advisory statement from the AHA that was published specifically on dietary cholesterol and ASCVD risk. As I pointed out, I think they have recognized that there is inconsistent evidence linking cholesterol intake and risk. And so in the advisory statement that was published a few months ago, their recommendations based on their review of current clinical data suggest that it's probably safe to consume at least 1 egg a day, or up to 1 egg a day, and that shrimp and other shellfish are okay to be consumed when they are paired with other lean or plant-based proteins. However, because of some concerns about the lack of clear safety of cholesterol consumption, they do suggest that patients who have underlying lipid disorders, diabetes, or at risk for heart failure, that those patients, they still recommend cautious consumption of cholesterol-rich foods. Again, highlighting the fact that we really have a lack of good clinical data to support higher intakes of cholesterol-rich foods. So I'm not going to talk too much about diabetes. Dr. Trigadinathan gave an excellent talk on the recommendations for diabetes management a few months ago. And Dr. O'Brien obviously has been actively involved in diabetes research at University of Washington. So I'm just going to briefly highlight diabetes guideline recommendations. And you can see that for patients with type 2 diabetes, again, there's a strong emphasis on nutrition, lifestyle changes to improve glycemic control, and to focus on optimization of atherosclerotic cardiovascular disease risk factors. And the second recommendation is around physical exercise. And then the first-line therapy, at least based on the recommendations that came out last year, was to use metformin as a first-line therapy for improvement of glycemic control and reduce ASCVD risk. And you can see that a 2B recommendation was given to the GLP-1 receptor agonists and the SGLT2 inhibitors. I can tell you that there is going to be a new expert opinion statement coming out soon where I think there's going to be some update to these recommendations based on new clinical data that has emerged, as you know, for these new classes of treatment. So let's go to exercise. I apologize to Margaret. This is the only picture I could find, and there's our Dr. Musavi. So they're both soccer players, and since my daughter plays soccer, I like soccer. So we're going to talk a little bit more about the exercise recommendations here. So guidelines that were published last year, you can see that exercise is vitally important in terms of benefit and integrated into all the prevention specific guidelines with respect to hypertension and lipids and diabetes. And so during each visit, we should be discussing and counseling patients on physical activity. And the guidelines recommend 150 minutes of moderate intensity activity or 75 minutes of vigorous intensity aerobic physical activity to reduce ASCVD risk. And so you can see here, I think sometimes it's hard to know what is vigorous and what is moderate. And so this gives you some guidance on that. So vigorous is jogging, running, biking, singles tennis, swimming laps. Moderate intensity activity, which is basically between 3 to 6 METs, include brisk walking, biking, active yoga, recreational swimming. So these are ways that we can inform patients on what types of physical activities represent moderate versus high intensity exercise. I think one of the things that raises a lot of controversy is too much exercise bad for you? We know that from many studies that overall physical activity correlates with lower ASCVD risk. However, several studies have been published that suggest that there perhaps is an association between high volume exercise and an increased risk of subclinical atherosclerosis that has typically been measured by looking at calcium score. So I highlight a Dutch study that was published in 2017 in patients who had a history of lifelong high exercise, lifelong activity. And you can see that they had clearly higher calcium scores and higher atherosclerotic burden with an odds ratio of 3.2. And that was based on comparing those who had more than 2,000 METs per minute per week of reported exercise activity versus those who had less than 1,000 METs per minute per week of exercise activity. But interestingly, when they looked at sort of the plaque histology, the group in the high exercise activity group had more benign plaques, meaning that they had primarily calcified plaques and they had less mixed or non-calcified plaques, which we associate with increased event rates, suggesting that even though these patients seem to have more plaque burden, they tended to have more benign plaque, which might explain why these patients could have lower event rates or potentially not having higher event rates. And that was confirmed, I think, in this large Cooper Clinic study of over 21,000 men who had calcium scores. And even though there was clearly higher calcium scores in those with the highest exercise group, which was defined as 3,000 METs per minute per week, interestingly, that the patients in that highest calcium score group that were most active did not have higher event rates versus those who were in the lower overall exercise group. Again, I think it's hard to take a lot from this study because the event rates were very low, and so it really didn't achieve statistical significance in terms of, even though there seemed to be lower actual event rates, they did not achieve statistical significance in this particular study. So I just want to highlight the Cardiovascular Wellness Prevention Program that Dr. Dresner and I started in 2018. And so we have several faculty members that are involved in this particular program. In fact, you can refer patients to this program in EPIC. And so Dr. Dresner in sports cardiology and family medicine, and I started this program in 2018, and we have other faculty members, Dr. Dean and Dr. Mormon from cardiology, and Drs. Pelto and Siebert from family medicine, who are involved in this study. So if you have patients who are interested in a comprehensive cardiovascular risk assessment, this is a program that we have just started, and these are some of the promotional materials that Dr. Dresner created for us. So I'm going to finish by talking about a case very briefly. So this is one of my patients who I actually just saw on Monday. So she's a 50-year-old white woman who has a history of mildly elevated cholesterol, but a strong family history of premature heart disease. You can see that her father had a heart attack at age 30, underwent bypass surgery at age 50. It's a brother with elevated cholesterol and a paternal uncle who had bypass surgery in his early 50s. So this is actually a very healthy woman. You can see her blood pressure is excellent. Her BMI is in an optimal range. She actually is very healthy in terms of her diet. She exercises twice a week and runs 3 to 4 miles without any limitation. So overall, she's a very healthy patient. And if you look at her labs when she first came to see me about 2 years ago, her HDL is quite good. Her LDL is mildly elevated. Her lipoprotein little a is moderately elevated, and her CRP level that we tested was really low. And then if we use the traditional ASCVD risk score, you can see that her risk is only 0.8%, which I think, she would be categorized into the low risk group, and therefore no intervention would be recommended. Obviously, the deficiency of this risk calculator is that it doesn't really incorporate family history and is non-discriminatory in terms of risk assessment for certain ethnic groups such as Hispanics and Blacks. So we clearly have challenges for using this risk estimator broadly and the accuracy of calculating risk in certain populations. So one of the things that I pointed out earlier was how the calcium score can potentially be used as a way to help push patients to more aggressive treatment or intervention versus those perhaps where calcium scores can be used to delay initiation of treatment. And so you can see that if the calcium score is greater than 100 or 75th percentile based on age and gender, that the recommendations include initiation of statin treatment. For those who have a calcium score of 1 to 99, it also favors statin treatment for those over 55 years of age. And a lipoprotein a level, which we often see elevated in patients with premature heart disease. If it's above 50 milligrams per deciliter or 125 millimoles per liter, is considered a risk enhancer and also may guide more aggressive intervention for patients with treating with lipid-lowering therapy. So for this patient, we actually decided to pursue a calcium score. So in general, in clinical practice, for patients who are over 40 years of age in men and over 50 years of age in women are when I typically perform a calcium score. And what you can see here is that this woman had a very small amount of calcium in her right coronary artery. Her calcium score was only 5, was in the 80th percentile for her age. And so as a result, if we were to use the clinical guidelines published in 2018, that would certainly be a potential indication to push this patient to treat her with lipid-lowering therapy. So options for this patient would be to try lifestyle intervention. So overall, her diet was excellent when we reviewed it quite closely. Increasing her activity level in terms of exercise could also be a way to try to improve her lipids slightly versus potentially initiation of lipid-lowering therapy. And for this particular patient, she was actually eager to start cholesterol-lowering treatment, perhaps based on the fact she had evidence of subclinical atherosclerosis. And you can see that her most recent lipid profile that was last year, we didn't get her labs from this year yet, that her LDL was at 61. And we did encourage her to increase aerobic exercise to at least 150 minutes a week. So my few take-home points here are that I think in the prevention guidelines that were published last year, that there's a strong emphasis and focus on lifestyle and behavioral interventions. In general, aspirin should be avoided for primary prevention. Blood pressure control is critical for lowering ASCVD risk, especially in light of the fact that we're seeing increasing rates of hypertension-related cardiovascular mortality from the recent NHANES survey that was published. The lipid lowering or the lipid guideline algorithm really the primary resource used for treatment recommendations. Smoking cessation needs to be addressed at every visit for our patients, and that we should be strongly informing them about behavioral and pharmacologic treatments that are available to them. Again, diet, I think, is a very important area that we need to be focusing on, and I typically recommend a Mediterranean diet for patients or a plant-based diet if they're interested. Again, the impact of cholesterol intake and ASCVD risk is really unclear, and in general, I do typically don't recommend high cholesterol foods in general for high-risk patients. Diabetes management really should be focusing on lifestyle and risk factor optimization. And then finally, we know that exercise is important, but we have some unresolved questions around whether there's an increased risk of atherosclerotic cardiovascular disease for those who engage in high volume exercise activities. So with that, I will conclude, and thank you for your attention.